Hello, my name is Tom Lavin, and I'm going to talk about obesity this morning. And Dr. Zeisler's talk was great. You know, I related to a lot of that because the change in sleep patterns has really resulted in a lot of our obesity problems. And it made me think of, I did a talk in Sweden about a month ago to the European obesity, and Sweden's 7 hours later. So I'm like, damn, I couldn't go to sleep at night. So I finally was starting to fall asleep about 5 a.m. But in Sweden, the sun comes up at 4 a.m. So the sun comes shine in the room, then I'm screwed for the whole day. So, you know, from his talk, it makes sense. But obesity is totally tied to what we do in obesity treatment. And just real quick, I started as an obesity surgical specialist 15 years ago. We became one of the busiest obesity surgical treatment programs in the United States over about 10 years. But then my vision turned more towards the problem, because I can make a huge impact on one person at a time, but the obesity problem in the US is just blown out of control. And we're going to get into exactly why that is, and it's going to be, really challenge a lot of you. You're not going to realize what's happened in the research world in obesity in the past 5 years. But it'll give us a lot of good ideas from ourselves personally how to fight this and how to maintain good health. And so the problem in the United States today is about $300 billion problem, treating obesity. That pales in comparison to where we're going, because of the pediatric obesity problem today is just tremendous. And we're going to get into a lot of that. So at one point I was only a surgical person, taking care of obesity that way. And now we've developed the whole medical, and now we're developing a big pediatric obesity program in New Orleans. So we kind of approach the whole topic of obesity, because from my standpoint, I'm a anti-traditional medicine guy. I don't believe in adding medicines and treating disease, which is basically the paradigm of the traditional Western medical program. I'm more about preventing disease, or at the very least, resolving it, as opposed to chronic treatment, which I think is bad. And I have patients come in with a baggie of like 28 medicines given to them by maybe 12 specialists that don't communicate. And I'll look at it like, holy hell, how does anyone even know how those things interact? So my whole goal is to get people off their medicines, lose weight, get healthy, and get back to living normally. So the hunger for weight loss, Janice came up with this idea, which is great, because so much of what we do today is, traditionally the obesity treatment was very dangerous, and people died, and there were a lot of complications. Today our treatments are either outpatient or one night stay. Patients, it takes about 45 minutes, they're minimally invasive, and some of them are even incisionless, endoluminal. I'll get into some of those that we've just finished an FDA trial for. So the whole treatment is going to a very safe, very effective treatment, and the treatment are metabolic, meaning they affect your internal hormones, which affect hunger and cravings, whereas traditionally people think about restriction. Restriction plays somewhat of a role, but it's definitely secondary to the metabolic hormonal changes we invoke with our treatment. So today, these are the two treatments that I do probably 90% of the time. Laparoscopic sleeve gastrectomy is the primary treatment today. People get confused. They think you slide some sleeve around the stomach. Basically, it's a 45-minute treatment where you remove about 85% of the stomach. So instead of a football-sized stomach, you have a more banana-sized stomach. And the beauty of that is the stomach does not absorb any nutrients or vitamins or anything. It's purely capacity and endocrine hormonal role. So there's no malabsorption from it. There's a restrictive role, but much more predominantly there's a metabolic hormonal control. So my patients after surgery have no hunger, no cravings. They go through their day without any of the hunger and cravings. And because we live with those hunger and cravings our whole life, it's hard to imagine. So I try to help them understand that. I say, consider going grocery shopping when you're starving and how your behavior is. Or you grocery shopping after a big lunch when you're totally full and those hormones are shut down. That's how it is after a sleeve. And so patients lose about 70% of their weight, get healthy, medical problems go away like diabetes, hypertension, they can breathe, they sleep better at night, have more energy, joints don't hurt, just all kinds of great changes. The second approved treatment is a gastric balloon placement. And we started doing that last summer. It's fresh out. It's more of a restrictive, but it's an outpatient endoluminal procedure that takes about literally 10 minutes. People go home about 45 minutes later. One of Dr. Najib Thomas's guys, he sent me one of his buddies, called me yesterday. And in the treatment, you're only allowed to leave them in 6 months because they're not tested beyond that. And he goes, Doc, I've lost 48 pounds. I'm kickboxing. I'm running miles. I mean, really running. You know, he goes, I feel great. I haven't felt this good in 30 years. He goes, I want to keep my balloon. I'm like, oh no, the balloon has to come out at 6 months. So his question was, how soon can you put one back in? Because I'm worried I'm going to gain my weight back. So that's so Ricky. I mean, he's such a fun guy. But anyway, that is a totally different procedure. It's not hormonal, but patients fill up on a small amount of food and they have less overall hunger. But once again, it's an outpatient 10-minute procedure. So compared to the treatments of yesterday that were life-threatening and drastic and dangerous, you know, we have some good treatment for patients that really impacts them in a big way. This is the gastric sleeve, as I was talking about. We go in laparoscopically through 3 little incisions under general anesthesia in 45 minutes, create a new stomach tube, but most importantly, we don't impact the whole small intestine. And you basically have 20 feet of small bowel to absorb all your nutrients and vitamins. So it's just a hormonal operation, decrease hunger and cravings, as well as a restrictive procedure. And we take care of patients from all over the country. It's, you know, a straightforward procedure. They come in for 2 days and they fly home, and then we follow them with their local MD up there. We take care of about 1,500 patients a year with the sleeve or the minimally invasive surgical procedures. This is a patient of mine, Annie, and we do a lot of pediatric. I'll do 13 to 18-year-olds that have, you know, they may have adult diabetes at age 14 with sleep apnea on a CPAP machine. So these patients you can dramatically impact, and of course the pre-op part with child psychiatry and all that, it's more intensive, but the impact you have on their lives is incredible. So this is Annie as a 16-year-old. She lives somewhere in Arkansas, and you can see how she looked, and she didn't have any medical problems yet, but certainly her quality of life was dramatically impacted. So this is 18 months later. That's Annie down 125 pounds. And she's now a freshman at the University of Arkansas. So this is the drastic change in patients. So you can imagine the quality of life from a girl that was going to be fighting her weight, making every excuse why she couldn't go out, you know, not really going on dates, nothing. And now she's just gorgeous and just a total change. This is the balloon procedure. So we basically go down with the tube. This is done not under general, just under outpatient sedation. Blow up one balloon, blow up the second, pull the tube out. These balloons basically have 450 cc's of saline in them. So you can see there is probably maybe 85% reduction in the stomach capacity afterwards. It is a straightforward, easy, safe procedure, but I tell everyone, you got 2 days of misery after a balloon. The worst part about the balloon is the first 2 days, it's rocky. People are sick, they're uncomfortable, but you come out of that after 2 days and then you're off to losing weight. Balloons, like I said, have to come out in 6 months. So this is a temporary attempt to recalibrate what we'll get into in a second, which is your set point, is why, how your brain has a set point of where its body wants to live. And we're going to get into that because that's new research over the past 5 years, and it's totally different from our traditional thinking that obesity is a choice. If you just eat less and exercise more, you know, you can lose your weight. And that, you know, every study shows if you're 100 pounds overweight, exercise and dietary limitation are not long-term solutions for the masses. It just doesn't work. Okay, so the pose is a procedure that I helped develop over the past 4 years, which is an endoscopic procedure. Once again, takes about 20 minutes. It's outpatient. We're able to reduce the size of the stomach, and it does have a hormonal decrease in hunger and cravings with metabolic changes. And we just finished a 2-year trial, and we're waiting FDA word right now. So once again, it's incisionless, endoluminal. We go down the mouth, and then I'm able to sew. So you go down with this transport, and it has multiple lumens. So one is a camera, so I'm able to look at everything in the stomach. I shrink this whole portion of the stomach by inverting the stomach lining and putting baskets in it, as you can see here. That's the suturing device. It puts baskets behind. So you create 2 rows of these pleated folds in the proximal portion of the stomach and then a distal row in the body. And once again, it takes about 20 minutes. Patients go home several hours later. And that does have an impact on hunger and cravings as well as capacity. Not near to the level of a sleeve, but once again, it's incisionless, endoluminal, so different level of invasiveness. So just very quickly, I don't want to get too much of the history other than to say, I call it the dark ages of weight loss surgery. When I went through training in the early 90s, my chairman basically said, don't do it, patients die, they sue you, it's terrible. So that was my training as I went through in the 90s. And all right. So basically the 50s, they had intestinal bypass. That's the old bypass where patients got malnourished and sick and had liver failure. And then the bypass started here. Bypass is and this is of course the whole open era. The gastroplasty was basically what they called the old stomach staplings, where patients lose all their weight and gain it all back. Someone said, oh, it doesn't work. They lose their weight, they gain it back. So, the whole history paints this kind of dark, ineffective, dangerous picture of what went on. Gastric banding started in the US in 2001. That was done laparoscopically. We quit doing those about 8 years ago, mainly because they don't have a metabolic effect. Patients don't have hunger control and craving control. And you do see some early weight loss, but sustained weight loss is pretty rare, and they have a lot of complications. So basically, we don't do any bands anymore. Sleeve gastrectomy, we started just about 10 years ago, and that's become the mainstay of what we do. And once upon a time, this is going back to the dark days. Basically, what they found is ulcer patients that had gastrectomies in the old days before Tagamet and all the drugs for acid. We did gastrectomies all the time. This is before I was a surgeon. And so from that era, we found out patients lost weight. So that's how the whole area of bariatric surgery started, basically. And then the open surgery days, they literally would keep patients in the ICU for a couple days. It was a different era, and once again created kind of a challenge for us laparoscopically when we started the program 16 years ago. But of course, people barely remember this today. High rate of postoperative complications, hernias, all of that. This is gastroplasty, which is basically where you just staple the stomach, and what would happen, that staple line would break down, so you go back to your old stomach pretty quickly and gain your weight back. This guy in San Diego, Alan Whitgrove, started doing laparoscopic gastric bypass in the 90s. It didn't really catch on until after 2000, but he really changed the deal, because the laparoscopic gastric bypass got rid of a lot of the complications of the open era, where patients could have this short, safer surgery and go home quicker. And the bypass, we still do them occasionally. It's very effective, but it has some complications that the sleeve does not have, and that's basically why I do sleeves probably 98% of the time on patients. This shows the transition from the open era to the laparoscopic era, which is basically about 2003-04. We started in 2000, and today, nobody does open bariatric surgery unless it's a revision and they have too much scar tissue. That's bypass. There's the band. The band, basically, you put a band around the proximal stomach, so you have this tubing with a port where you can adjust it. And once again, we just don't do those anymore. When Chris Christie had his, I'm like, why is someone doing a band on Chris Christie? It's, in my opinion, outdated medicine. This shows the procedures over time. You can see the sleeve starting at about 2010, just going up, and the bypass and band going down, where bands, there's hardly any bands done today. And bypass is still done. It's still a good procedure, but I find the sleeve just safer and equally as effective. Okay, this is where it's really going to challenge people in the room. The energy balance, okay? Once again, I grew up with the idea that if you just eat less and exercise more, you can overcome this problem. Well, if that was true, we wouldn't have this dramatic obesity problem today in the pediatric population that is just frightening. They just came out with the study that 40% of American women are obese and 35% of men, which is crazy. I mean, that's a BMI of 30 or above, and that's getting dramatically worse year by year. So basically, these are the three premises that over the past 5 years, all the research has showed. Energy balance is complex and highly regulated. By energy balance, just think of fat stores. That's our major energy for our body, our fat stores. And so it's complex and highly regulated, and the body has a set point that is regulated by many ways that wants us living at a certain weight. And when we try to overcome that, the body fights it by hunger and cravings and decreasing our metabolism. And so I'll get into much more on that. And like I said, the body regulates the body fat, and it dysregulates to a set point way too high. Because I think back to, I grew up in the 60s and 70s. In school, I had two kids that were overweight, Chuck and Brian. I remember them well. That was it, you know. They were big. They like beat small guys up, you know. But everybody else was skinny. You know, today it's kind of the other way around. So, you know, bad things are happening. So I was thinking, we're Chuck and Brian today. I mean, probably not good if they continue on that pathway. So the dysregulation, we're going to get into that. Why are we dysregulating to this crazy set point where somebody wants to live at 300 pounds and the body fights, you know, that weight? And then today, bariatric surgery works by changing signals that regulate body fat stores. So when we operate, we change all the hormonal inputs to the brain. So now instead of the body wanting to live at 300, it wants to live at 180. And so you gradually go back to this new set point. So all of the research, you know, says this is true, but the question is, how does bariatric surgery do that? Can we do that without, you know, having to go through surgery, or can we do it through less invasive ways? So once again, I'm a surgeon, but I've taken a step back, so I can impact one person at a time in a dramatic way, and I do it all day, every day. But I'm having no impact on the overall problem in the United States, which is a big problem. So that's why we're developing the whole pediatric obesity and the research program, trying to figure out how do we impact kids today and turn things around, because if we don't, I mean, it'll crash the whole medical system in the United States. Physiologic changes in body weight set point, like I said, that's how bariatric surgery works. We'll get into some details on what those signals are. Most of them are gut hormones. When I went to med school, I didn't realize that the GI tract was an endocrine organ, like a thyroid gland or adrenal gland or ovaries or testicles. It's an endocrine organ just like that, produces protein hormones. These protein hormones have a lot of impacts, but they impact hunger and cravings at the brain level and try to protect this set point that our body wants to live at. And then secondarily, it works by mechanical restriction. Obviously, if you take a football-sized stomach and make it banana-sized, you can't fit as much. But the more important side of it, you don't want as much. And there's even a shift towards healthier food. Improved health after surgery. One of the biggest ones is diabetes. Diabetes resolution is very high afterward. It shows resolution of diabetes in the 70% range and improvement in the 80+% range after a procedure. Most of that happens before weight loss from the hormonal changes from the GI tract, which is something, of course, we didn't know. Hypertension, sleep apnea, high cholesterol, all dramatic improvement in these problems. Obviously, patients aren't born with these problems. They come over time as you gain weight. This is a girl I operated on, you know, I think she was 39 and just a typical kind of mid-age female. And she's kind of telling the changes, and it's just dramatic when you see it. And this is over 9 months. This is after about 9 months.
Hi, I'm Heather. I had gastric sleeve in July, and since then I've lost 130 pounds, and my blood pressure was high before surgery. Now I no longer take blood pressure medicine. The only medication that I take at all is my vitamins, and I feel wonderful. And since surgery, I do CrossFit 3 or 4 days a week. I've run 5Ks, and my energy level is increased greatly since surgery. Nothing really stops me anymore. I definitely cross my legs all the time, whereas I didn't do that before, and that's pretty much the only way I can sit anymore. And it's crazy to be from a size 28 to a size 12, and they're starting to feel big. So it's definitely changed my life for the better. and I'm excited to see what's going to happen in the future. And I'm about to be 40, so this is huge for me. I'll be 40 in June, and I never thought I'd weigh less than 180 pounds because it's probably been 15 years since I weighed, well, I don't think I've ever weighed that since high school. So I've been 300 plus pounds for probably 15 years now. So my life has dramatically changed, and I would definitely recommend this to anybody who is overweight and feels sluggish.
So it just gives you an example. And so we get to see that in clinic, and it's just crazy to watch the impact on people's lives over a very short period of time. This gets into the obesity-related illnesses, and there are greater than 65 of those that come with the weight and go after a bariatric surgery. Of course, diabetes is probably the big one, and now the ADA is recommending bariatric surgery to treat it. But there's everything from NASH, the liver disease, all the pulmonary diseases, cardiovascular, depression, hyperlipidemia, obstructive sleep apnea. That is, patients like Dr. Zeisler was talking about, the obstructive sleep apnea, where they can't sleep and they obstruct at night and they end up dying younger. This resolves that because, like you said, the risk factors are obesity, obesity, obesity. So we have a big impact on that. And one of the things people don't know is cancer. Obesity has a very bad impact in the inflammatory pathways in the body and the immune system. So our immune system is not nearly what it should be when we're obese. So cancer is much higher prevalence: breast cancer, ovarian cancer, prostate cancer, colon cancer. Not only that, but the return of cancer. So I see the oncologists send me a lot of patients that had prostate cancer, breast cancer, and they're obese, so they can lose weight and then significantly decrease their chance of recurrence of cancer. This ADA statement: bariatric surgery leads to a major improvement in patients with diabetes or even complete disease remission, which is a bold statement from a medical society. This is one of my partners is a female. In fact, her and her husband are both my partners. Those two operating together could be a comedy. But this is her slide. My daddy is a doctor. He treats diabetes. My mommy's a surgeon. She cures it. Diabetes resolution. I remember my first patient, Randy, when I did my first laparoscopic bypass 15 years ago. He had been on insulin for about 8 years. He went home after 2 days off of insulin, off everything, with blood sugars that were approaching normal. So that's when I realized there's a big impact here. Diabetes improvement and resolution after bariatric surgery, not dependent on weight loss. So that's something nobody knows. So the impact on the hormones that affect everything in our body also causes this quick resolution of diabetes. And it does it by increasing insulin secretion from the beta cells in the pancreas, as well as increasing insulin sensitivity. You're no longer insulin resistant, you're insulin sensitive. And so you hear the buzzword insulin resistant all the time. So that is the way that bariatric surgery does it, and it does it by impacting a lot of factors in the body, predominantly those hormones from the GI tract. These are the paradigms that will challenge people. I'm going to talk about them relatively quickly because our time's short, and we've hit on it a lot. But weight cannot be reliably controlled by voluntarily adjusting energy balance through diet and exercise. That's number one. And all research shows it. That's why our obesity problem is flying out of control. You develop this dysregulation of a set point in our brain based on our multiple factors: the Western diet, the lack of exercise today, the lack of sleep and sleep disturbances, as well as stress levels in our daily life today, and medications. So many medications for depression and anxiety, they cause weight gain. So we've created this Western environment, diet, as well as all these other factors that have led to this dysregulation of our set point, where our body wants to live at this new, heavier weight. And so that's probably the biggest problem. Bariatric surgery impacts that set point. And we're trying to learn exactly how it does it, so we can see if there are other ways we can do it and really impact, either prevent this dysregulation from happening, or show people how to change it. The sleeve gastrectomy is A metabolic procedure, which just basically means it impacts all these hormones, and diabetes improvement after bariatric surgery is not dependent on weight loss. That was a big revelation for us. And patient behavior is not the primary determinant of outcomes after bariatric surgery. So I tell people, you have to be on my team. This is not magic where I just do something, and most of my patients are mature adults, although I have a lot of adolescents too, that, they're on the team one day and maybe not the next day, so like all adolescents. So, but we do make sure that people are, ready. We don't rush into surgery. There's a lot of evaluation and education ahead of time. However, at the end of the day, the procedure works on patients that don't do anything. It works way better on patients that are on my team and do the right things, but it works pretty well on patients that are really bad patients. Whether that's good or bad, I don't know, but it impacts them also. Okay, so this is going to get into what the hell is going on. Obesity's perfect storm. So here's, we call her Amanda, and this is the rate of obesity skyrocketing in the modern environment. Like I said, today we've got the Western diet with less nutrients, trace hormones, trace antibiotics, just this highly engineered food that is out there everywhere for us. It's cheap, it's high in calories, and that wasn't around 25 years ago. In addition to that, exercise is way less today. Everyone's running, everyone's stressed, everyone's going 100 miles an hour. We don't have to walk inside to pay for our gasoline anymore. We never walk them downstairs. So everything's changed. You never walk in a city. If you go to Europe, everyone walks. Nobody walks. Our cities aren't set up to walk. So exercise has really decreased. And on the pediatric level, I was out playing all the time. Well, guess what? Kids are on their little things all day, every day. So it's just our environment has totally changed. Increased stress, decreased sleep patterns. When our kids were growing up, it's funny, they were 2 years apart. We have three kids. They're 20, 18, and 16 now, but we made them go to bed at 7:30. 7 o'clock was baths, 8 o'clock was to bed. And that worked great when they were 2, 4, and 6. And about when Sean, my oldest, turned about 14, he's like, what the hell? It's 7:30. I'm 14. I'm like, or when the time changed, it's light outside. I'm not going to bed. It's light outside. I'm like, you got to go to bed. So, because soon I'd be dying to, we need some alone time. So we were pretty rigid about sleep, and I think it had a good impact on the kids. But it's hard to do that. And sleep disturbances are so profound. And then, of course, the medicines we take today with so many of them lead to weight gain. And so these are kind of the factors that we can all do to impact ourselves, fighting the Western diet. You really have to take control. Processed food's bad. You have to resist the things out there and really plan meals. You have to implement some kind of exercise program. What I did is I started doing it at 6 in the morning, because at 6 in the morning, my time is my time. No one else is up to tell me what to do. So it's great. So I get to work out. By 3 or 4 in the afternoon, man, I got too much direction from, too many family responsibilities, work responsibilities. So for me, I had to work out early in the morning. Increased stress. Everyone's stressed out today. You have to find a way to deal with it. Stress is part of life. You've got to find a way to deal with your own stress in your own life. And there's lots of ways you can do that, but people really have to do it. And then, of course, you have to get sleep. There's no reason not to get adequate sleep. Let me say, we can find a lot of reasons to get lack of sleep, but it's going to impact your life and your health and everything in a very bad way. And so, and then medicines, if you're on medicine, check them out, because like I said, I have my patients come in with this bag of medicines. It just terrifies me looking at what they're on. And once again, I try to get them off as much as possible. Energy balance, weight maintained, what goes in equals what goes out. So basically what your calories, your energy going in, you have metabolism plus exercise. If they balance, the energy balance equation says you don't change your weight. If what you put in is more, you're going to gain weight. If what you burn is more, you're going to lose weight. So the myth is obesity is a lifestyle choice. And really, I thought that's how I grew up. Exercise more, eat less. That's what every doctor will tell you if you're overweight, because, they don't know any different, So the reality is that although this sounds logical, it's not really correct in that is not an effective solution for our obesity problem, because it's not working. And so the set point theory, that's how we've come up with this over the past 5 years and $100 million in research and so much money and so many programs. So basically what happens is the brain gets feedback from all over the body based on your leptin and other hormones from your fat stores and your muscle, your liver, your bone. Everything's feeding back to the brain, trying to keep you at a certain level of fat stores. And your body will defend that, okay? So it's very complex, and there's a range. It's not exact pounds. Maybe it's 250 to 270. Your body likes that range. And when you, and you can see all the feedback here from muscle, bone, liver, pancreas, GI tract, everything, hormones and neuronal input to the brain. And the brain is going to defend that set point. So when you start dieting, okay, your weight's going up, you are going to eat fewer calories and your hormone levels are going to go up, trying to maintain that set weight point. And the two things it's going to do, it's going to drive your hunger and cravings up and then decrease your metabolism. So it wants to maintain that weight. Here's a little graph that says the same thing. You gain weight, so you have diet and exercise to reduce the weight. You're doing the right things. And I totally believe in diet and exercise. No matter what, you need to do that, but you be healthier. But to lose 70 pounds through diet and exercise, it's just not very common. In fact, I don't know anyone that's done it and kept it off. People can do it. I mean, people come in and say, I've lost 1,000 pounds in my lifetime. I'm like, because it's just a yo-yo. They do it, but the hunger and cravings and the body set point drives them back to that level. So the hormone levels adjust to promote weight retention at that point, and you have increased appetite and slowing of the metabolism, and you get your weight gain. So it's just the yo-yo. Lose weight, gain weight, lose weight, gain weight. That's basically the life cycle of everyone fighting their weight. And so this dysregulation to a set point that is too high, the body doesn't know this is an unhealthy set point. It's just our Western diet and all these factors in our lives today that have dysregulated this. And so now patients are just, they're battling it, and the doctor tells them, exercise more, eat less, which is really the right thing, but it doesn't have a long-term solution. Bariatric surgery lowers the set point once again, and we're trying to figure out why and in how we can impact those changes in other ways. Once again, we can change the set point. Diet basically fights the set point. In the takeaways, energy balance is complex and highly regulated, which I've gotten into. Obesity is a disease where a complex system that regulates fat dysregulates to a point that's too high. And bariatric changes these hormonal signals to reset the set point and help people lose their weight and keep it off long term. And I'll stop there and take questions. Yes.
Okay, so I have been reading. Thanks. Sorry, I've been reading recently about the newly understood relationship between their gut biome and obesity.
Yes.
And I read the craziest thing where they were able to take and transplant
bacteria in the
bacteria, we'll just say, from thin people into obese people, and those people became thin.
Right.
So obviously there's some sort of strong correlation. I'm curious to know.
There is.
Yeah, what if you can speak to that?
So I haven't gotten to a lot of depth on, because it's really complicated, obviously, but this complex regulation of this set point, one of it is your gut microbiome, the bacteria in your gut. And obviously the Western diet with trace antibiotics is going to alter that over time. And so that's why probiotics and those kind of things play a role in trying to avoid, eat healthier foods, non-processed foods. But it's really hard to find non-engineered foods in our society. I mean, you almost have to have your own farm that raise your own crop and all that kind of thing. So, but you really have to fight it. But there is research that says if they take, and they don't know if that's genetic DNA, that even to the point where a new doctor I'm bringing on with me is doing research on the DNA and the upregulation of genes for obesity from the Western diet and these influences that we have. Upregulate these genes that weren't expressed 20 years ago in our thin, population, that now based on the exposure to the Western environment, these genes are being expressed and creating this dysregulation set point and obesity. So that's a key part of it that people are looking at. I don't know how many people are going to want their bacteria in their gut transplanted, but it's great research because that's part of the picture. Yes.
Is there a time frame by which your brain kind of shifts its expectations? So if you kind of shift your diet and lifestyle habits for say 4 weeks or 2 months, which is a long time and very difficult, I'm sure, that then the brain's going to shift and its expectations are different.
That makes sense, and we think that to be true because in the balloon, which gives you a 6-month window of help, then they remove it and you're on your own. Most of the patients will keep their weight off or continue to lose weight. So we think the longer you do it, the better your impact in changing that set point. But that's one of the hot areas on what does change the set point for people. So, but common sense would tell you it does, and there is evidence that it does. Yes.
So you've indicated that diet and exercise really doesn't make a difference, but for those that do exercise, you're getting rid of your fat and converting it to muscle.
Right.
So you basically, you can maintain your weight. So how does that affect the set point, and how do you adjust it without having to go through the procedures that you've discussed?
Okay, what I would say, I recommend diet and exercise to everyone. And I do it, and I think it's a key factor in taking charge of your life, and I think it will have an impact for most of us in this room. It doesn't work for, and once again, this is taking a step back and looking at the masses. Like how many people that are 100 pounds overweight, if you just do diet and exercise, are going to lose your weight and maintain it? Close to zero, okay? So it's not an effective solution for our problem, but it may be a very effective solution for me taking charge of my life. So I'm not, again, I think that is a great thing, and it's part of you taking charge of your life. But when you look at the big problem, right now it's not an effective solution because we're losing ground. And who doesn't say, hey, just eat less and exercise more, and you'll be fine. Yeah.
At what point of weight? The microphone?
Sorry. So, how much overweight do you have to be a candidate for something like this? I mean, like if you're 10 pounds overweight, you could probably work it off, or 20 pounds overweight. What's the point that you're over your weight limit for your body that you go through something like this?
For the incisionless procedures, and the only one approved right now is a balloon, we look at 25 to 50 pounds overweight, okay? When people get up in the 70, 80 pounds overweight, unless they just totally have an aversion to getting a sleeve, then a balloon will help them a lot. It just won't get them where they really need to be, where I know a sleeve in my hands is extremely safe and it will get them there. So the sleeve is more in the 60 to, heck, I have people hundreds and hundreds and hundreds of pounds. I mean, some of my patients are 700 pounds, so. Yes?
One of our relatives had, we think it was the staple thing, and then she gained all her weight back.
Right.
So now, years later, can she come in and get the sleeve? Is that safe?
We do a lot of revisional procedures in people that had all kinds of mysterious operations in the past. And usually the hospital shut down, the doctor's dead, the records are gone, and we have to just go and do upper GIs and figure out what the anatomy is. But there will be a solution for her, whether it's a sleeve or a bypass, which once again is very effective, but she may have burned her bridge for a sleeve based on what she had in the past. Yes?
Is there any excess skin left over when you lose that amount of weight, and how do you deal with that?
So that's a question from everyone when they come in, particularly ladies. And I work with some fantastic plastic surgeons. One is Dr. Thomas's wife, Summer, right back there in the back. And so her and her father, how many of my patients do you think you've taken care of over? Hundreds and hundreds and hundreds of patients. So, and they're phenomenal because they operate together and they do everything pretty quickly, which makes it much safer. So absolutely, I'd say maybe a third to a half my patients will need something down the road or want something. So, and what I tell them is lose your weight, resolve your diabetes and hypertension, get feeling good, get back to living a productive life, and then at 18 months you can get evaluated for that.
And this is truly a life-changing surgery for these patients. The patients that need these surgeries and get them do tremendously well. It's my favorite group of patients to see is their patients. It completely changes their life, and they come in. They're my patients that come in and are happy before we even operate on them. which typically leads to a patient that's happy afterwards as well. And so it completely transforms their entire outlook on life.
And that's why, we have two groups of patients. One, it's like they want to cure their diabetes and all these medical problems. And we also have the 14 to 30-year-old female that really doesn't have any medical problems, but they're depressed. I have suicidal high school females that they won't go out, they won't do anything, they make excuses for going out. And when they lose their weight, they smile, they transform, they go back to living life. So I don't know which one has a bigger impact, because I get excited watching that young person start living life and being healthy and going back to a normal life and normal relationships and jobs and promotions and going to college and all that. So okay, I'm available for I'll come down.
Can I shout it or?
Last question, then they're going to kick me off here. I'm going to get the boot.
Viability for your, let's call it sleeve, based on your age.
I do probably 13, 14-year-olds up to 80-year-olds, and so pretty wide range of patients. I had an 80-year-old guy, used to run numbers for the mob, he was just 320 pounds, man. I'm like, what's your secret? He goes, wine and women, man. I'm like, so he's 320 pounds, and but he's 80, still living life. I'm like, man, you got it. So he did great. He was flirting with all my nurses every time he came in. It was great. So there's any age range.
Do you see an excessive range of candida and intertrigo with your patients?
No.
There's no rashes on skin.
Yeah, for sure. Patients will have that, and they'll be getting treated. So these are skin rashes from skin folds, whether it's the pannus down here, breasts, or that. So patients have a lot of excess skin. So they're going to be chronic treatment. I was thinking you meant in the GI tract.
Oh no.
But certainly in skin folds, absolutely, they're constantly being treated with antifungals. Okay, I'm available for anything, so good.